Good evening, everyone. I'm Dr. Praneeth Palumuri. I'm a cardiologist working at KIMS Hospital, Secunderabad. I am joined by my co-host, Dr. Anoop Agrawal, who also works with me at KIMS. We both are cardiologists. Weekly Huddle, most of you already know, is a casual discussion kind of a thing, which we started about close to 2 years now. The entire theme is to pick up a clinical topic, understand the science behind it, and try to kind of get these guidelines or practice patterns or what we learn in textbooks into more practical way of how do we manage, learn from each other about practice patterns so that we learn from each other. We pick a topic every week, and this week it is our session 125. And in today's topic, we want to discuss about pain management. And to do this discussion, we pick a case. So I will tell the details of the case. We take a few opinions, and to facilitate the discussion, we have experts. I have called my friends and colleagues to help us learn in this discussion. We are joined today by Dr. Hemchand, who is a consultant orthopedician at Zoy Hospital, Attapur. We have Dr. Nagalakshmi, who is an pain management specialist. She runs her own pain clinic. And we also have Dr. Vijay, who is head of the Department of Physiotherapy at Uchwas Rehabilitation Center. Thank you guys for joining. So to tell us about this case, this patient is a 69 male, hypertensive, dyslipidemia, and benign prostate hypertrophy for which he is taking medicines. Otherwise, no comorbidities, physically active, kind of does his own activities. While he was traveling on a bus, and when he was standing and was holding the rod of the bus driver applied brakes suddenly, and because of the sudden application of brakes, he sustained an injury to his right hand through which he was holding the bus. Because of the jerky movement, he felt a catch in his right shoulder, and he did not have much of a problem at that time. But later, he gradually developed some pain and restriction of movements in that right shoulder where he sustained that injury. This pain gradually progressed in the next close to 2.5 weeks. The pain was a bit intense, which led to restriction of movements on the right shoulder joint. He tried some home remedies, took some paracetamol, applied some warm compresses, but it did not show any significant difference. He also tried some exercise on his own at home, but there was not much of relief. So he tried to tolerate this pain and did this his remedies for another 1 to 2 weeks, and because there was not much of a difference, and he finally decided to consult an orthopedician. Orthopedician looked at him. He looked at an initial evaluation, and an X-ray of the right shoulder joint was done to rule out any bony injury. There was no bony injury, and it was concluded to be a soft tissue injury. He was advised for rest for a few days with some analgesics, and following which he was asked to consult a physiotherapist and to get a guided physiotherapy to get his movement back. So after close to 10 days of rest to the shoulder, he worked with the physiotherapist, and guided physiotherapy sessions led to his recovery. He regained most of the movements of the right shoulder joint, and there was also a significant reduction in the pain. Now, close to 3 months post this event, he has regained almost 80% of his movements in the right shoulder. He's able to carry his day-to-day activities. It doesn't bother with his day-to-day activities, but he still continues to have some pain. The movements are close to restricted, particularly in the end range of movements are restricted. And there is also some pain which doesn't bother him while he's in the morning times, but during night times he could definitely appreciate some pain, which sometimes is severe enough to disturb his sleep as well. He tried taking the same painkillers here and there, but is equally apprehensive and he doesn't want to continue taking these painkillers, and he kind of is uh, bearing the pain and is kind of getting along. So this patient who had a blunt injury to his right shoulder and close to 3 months after the injury and doing some physiotherapy, and the only concern right now is his pain, which is bothering him. The restriction of movements is also not much because he's still able to carry on his activities. So the whole question today is, how do we manage this pain? What is the current drugs that we need to do? The main discussion will be, how do we approach this case further? So we have few questions which we already put it in the chat box. As a customary, I start with opinion from my co-host Anoop. I take his opinion, and if there are any other opinions, and then we'll go to the specialists that we have today. So Anoop, this patient, if has come to you for management of hypertension, and when he discusses about this recent issue which is bothering him, how would you manage his pain? Do you refer this patient to orthopedics, or do you do something from your end? And how do you do? When do you refer to a specialist, and do you see a role of pain clinics, and what is your overall impression on this patient, and how do you manage? Over to you.
So, Pranit, few questions that I have. Number one, when was this injury? How many weeks ago? I missed that part.
Close to 3 months from now.
3 months. And was there any imaging done to that shoulder, like an MRI or anything like that?
X-ray of the shoulder was done. MRI was not done.
It was not done. And it's only one joint pain, right? There is no other joint pain associated, right?
No.
Right. So I'll tell you my impression, Pranit, at the face of it, it looks like there is a stretch injury or a minor injury, as to speak. And most of the time when we have joint injuries, we tend to favor putting that joint to rest. And when that happens, then eventually it either we end up into kind of a frozen shoulder kind of situation, where now it's a vicious cycle that you don't do much exercise because it hurts, and because you splint that joint, the so-called stiffness keeps increasing. So what I typically do is I first make sure that there is nothing particularly important that I'm missing. From a cardiology standpoint, I make sure that there is no hemarthrosis or anything, because a lot of my patients are on anticoagulation. The least I can do is I can check their vitamin and D and calcium level to make sure they are optimal. And then I do send them for physiotherapist, and I give them a muscle relaxant, typically peripherally acting muscle relaxant with paracetamol or something, with the hope that I will be able to break this pain cycle, and then they will be able to exercise. In this particular case, there is enough exercise which has already happened. I would say enough because it seems like he did 1 month of guided physiotherapy or supervised physiotherapy, but he's still not back to normal. This disproportionate of his injury versus pain, that bothers me. So maybe it is not the injury which is creating trouble. Maybe it is just the stiffness post-injury where he didn't move his joint that much. That is where it is creating trouble. Many of the times, these joint issues, we favor orthopedician. But whenever I have situation like this where the pains are just not getting better, I have a very low threshold of taking rheumatologist's opinion to make sure I'm not missing anything, because there may be a predisposing reason why even a minor injury led to almost a 3-month kind of morbidity now. And then other than sending to physiotherapist, there isn't really much that I can offer to this patient. I particularly do not order MRIs because I don't order any test which I can't comprehend. So, and MRI shoulders first, the indications kind of it, and also once I get the report, I don't find myself competent enough to interpret that. So I leave the imaging analysis to orthopedician or the rheumatologist. Physiotherapy in pain management, I understand that eventually when they use their muscle, once the muscle becomes relaxed, the pain will go down. But it is the early on when there's a stiffness, and that is where I think the muscle relaxant helps. Role of long-term pain management, I hope that this injury doesn't lead to a long-term pain syndrome for him. But I'm sure there are patients who have got some old orthopedic injury and now they are just dealing the pain aspect of it with maybe with or without some deformity. There could be some role of long-term pain management. I again have less idea about it. Pain clinics, that was a very routine thing for me to send patients to way back in my training days in US. In India, I have not sent any patient particularly for pain management so far. Because the way I realized was that a lot of that pain management was surrounded by use of opiates. And in the last few years, we have heard about all the bad things of opiates. So I don't even know what is the current status of pain clinics in US. But I do know that anesthesiologists or experts or people who have expertise on this, they can use neuromodulators or they can do selective neural blockade, which can lead to kind of a relatively long-term pain control, maybe like for a few weeks to months. Just that I have very limited exposure to that part only. So when this patient were to come to me, other than making sure that their vitamin levels are okay, their metabolic parameters are okay, they don't have an uncontrolled diabetes, which is leading to myopathy or whatnot, and maybe seek a rheumatologist opinion also to make sure I'm not missing anything. Other than that, at my personal level, I don't think I'll be able to add any more value.
Who would you refer this patient first, orthopedician or a physiotherapist?
So orthopedic he has already seen. So I would do both. I would send this patient to a rheumatologist just to exclude, not that I'm suspecting any rheumatological problem, because seems like there is a clear onset of illness. It's just that the illness has progressed. So while I can take my own history and make a clinical assessment, it doesn't hurt to take a second opinion. So I would send him to a rheumatologist just to make sure that our assessment is correct. And secondly, I'll send for a physiotherapist along with a painkiller, like like that paracetamol and a muscle relaxant combination, which I'll give him, which I'll tell him to take about half an hour before the physiotherapy session, and then do a proper physiotherapy where I'm sure they have their exercise programs where they can do muscle stretching and whatnot. I'm guessing that is what is being done. Whether there is need for imaging to look for any tendon injuries or anything of that sort, that I will lead it onto either an orthopedician or a rheumatologist to make that decision.
Okay, thanks, Anoop. I'll invite Dr. Hemchand to share his comments. He was the orthopedician who saw this patient. So, Dr. Hemchand, you can walk through us. What was your initial impression when you saw this patient, and how did you guide this patient? What were the specific instructions that were given to the patient as to supervised physiotherapy, and how do you look at this case now that post 3 months, when he continues to have pain? How would you evaluate this patient? Do you recommend any investigations, or what are your thoughts on this patient? Please share your opinion on this case.
Hello, good evening, everyone. As the patient is a 50 to 55-year-old male, he never had a shoulder pain before, and he has a history of jerking his hand when he was actually traveling in the bus, as you said. That was 1 month prior. So usually at this age, usually after 50s and 55s, who have diabetes, if there is diabetes, it is a risk factor for frozen shoulders for the patient. That is one. Second thing is The injury also can cause a pain, as Anoop has mentioned prior. The injuries can cause pain, and the pain makes the patient to actually give it rest, and the rest imposes the frozen shoulder, and that's a vicious cycle which starts. Here, when I have seen the patient was already 1 month after the injury. So we usually are orthopedicians, when we examine the shoulder, we see for the movements. So in this patient, there was a pain in flexion and abduction over 80 degrees tendinitis. That could be a tough tendinitis, or it could be a tough tear. But because the patient was able to do active abduction and flexion, the tear is very less likely, and if at all, it could be a partial tear. The complete tear is very unlikely. That is one. Second thing is he even had a restriction of rotations of the shoulder. That says that the frozen shoulder has set in, which is preventing the movements of the shoulder because of the capsular contraction, which has happened because of the rest and post-injury because of the edema and healing. So usually for this patient, the recovery usually is long. It's not very short. That is one. Second thing is what we usually do is, I usually do is I'll get an X-ray just to make sure that there is no bone injury. That is one thing. And it is very unlikely because it's already a 1 month of time he has presented. So the pain is not that much. Usually we actually get X-rays to just see if there are any degenerative changes in the shoulder. Here in this case, there was no degeneration changes in the shoulder. That could be the reason for the pain in the shoulder. So that was ruled out. Second thing is there could be some degenerative changes in the acromial tip. The acromial tip, if there are any degenerative changes, the subacromial space usually decreases, and this acromion has a tendency to actually irritate and injure the rotator cuff, mainly the supraspinatus tendon, which can cause the tendinitis, or which can, on trauma, it might even cause tear. So that was not very prominent here. So the acromion causing the impingement is also ruled out. So it was a regular common injury where the patient gets injured, and because it is a very minor, he doesn't go to a doctor and he gives rest, and then it also causes what do you say is a frozen shoulder, that is restriction of the movements. But the patient still does his daily works where the tendon is still getting irritated. So here there are two things when I've seen the patient. One is this cuff tendinitis, which requires rest. And the second thing is the frozen shoulder, which requires mobilization. So usually what we do is we give some painkillers, anti-inflammatories for about 10 days or so, and we will start pendulum exercises of the shoulder. And the main idea is when the patient actually abducts his shoulder, that's when the impingement happens to the supraspinatus tendon, which is already injured, and that pain doesn't go away. So usually we ask the patient not to flex and do abduction over 80 degrees, so that we don't cause the pressure on the supraspinatus or the rotator cuff again and again, so that the swelling subsides. And it usually takes a period of 3 to 6 weeks for the swelling to come down, the tendinosis to come down. So usually when we give rest for about 2 weeks or so, along with the anti-inflammatory, and the patient shows very good pain relief of about 50% in this 10 days to 2 weeks. And after 2 weeks, we'll start actually mobilizing the shoulder. That is mainly for the capsular stretching to get back the rotation movements. That is for the treatment of the frozen shoulder. That's what I did for this patient, and as expected, he was responding very well. For the first month, as you said, he has regained his almost 80 degrees of movement with the physio. with the physio, and the pain has come down a lot better. But here the recovery is not complete, and it is not. It usually takes time. It might even take 3 weeks to 3 months to 6 months of time, because the capsular stretching has not been done completely yet. That has to be done. So the physiotherapy needs to be continued, and because it is 80% relief, then I would say actually he is recovering. If there was no decrease in the pain, or he is not getting the movement, what we usually do is we'll get an MRI just to see if there is any rotator cuff tear. If there is a tear, which is a partial one, we usually end up with physio only. We'll try to, because partial tears usually heal. If there is a complete tear, then yes, he might require a surgery, that is repair. Here, because the recovery was good and about 80%, it is in the usual line of treatment only, and he was responding well. But the complete recovery doesn't happen in a month or two for these patients, and it usually takes about 3 to 6 months, depending upon how good he is doing with the physio and how he's taking care of not injuring the tendon again. That is one. Second thing is, for this patient, usually it is the night pain which bothers them, because in the at the time of sleep, the positions of the shoulder might vary in the sleep, which can cause that end part of the capsule which has not still stretched to stretch, and that can give rise to pain. And that is the reason why these people have disturbed sleep, because once in his sleep he cannot control his movements, and once the movement is happens where the capsule gets stretched, which is actually contracted, that gives rise to pain, and that disturbs his sleep. So usually what we tell the patient is to position himself so that even in the sleep, the shoulder doesn't go into wrong positions where the capsule gets stretched, and that can give rise to pain and cause the disturbance in the sleep. So we usually, as per me, after 1 month, 80% recovery, it's a good recovery, and he is still in the path of recovery. It has not ended. He has to continue his physio and take care of the positions, and by 1 more month or 2 months, he should be all right. That is one. In case if he is having pain in between, then I usually add Dolo or something only when he's actually having pain. Otherwise, I would actually ask the patient to continue his hot water fermentation, and which he's doing it already, to continue that along with some ointment, and just continue physio. That should take care of the things.
Hemchand, any role of intra-articular injections, maybe like steroids or some other drugs which are available, which commonly are practiced in the knee space, do they have any role here?
Again, the same. If once we give the patient rest for the 2 weeks and we start physio, if he is able to do the physio and his capsule is getting stretched and there is an improvement in the movements, movements have been improved, there is an improvement, then you don't require any other additional intra-articular injections. If the patient is having pain and he is unable to do the physio because the pain is too much and he could not do the stretches, so there, unless and until you do physio, the stretching doesn't happen. And for the stretch to happen, his pain has to come down. And with medication, if that is not coming down, then yes, we usually give an intra-articular steroid at that point of time, not as a starting initially. I at least give 2 weeks of only medication and physio. If that doesn't help him, he's unable to do physio, then yes, I give intra-articular steroid and then ask him to go for the physio. That helps. But not in this case, because he has actually responded well with medication and he's in the path of recovery.
You mentioned about the posture that need to be maintained while sleeping. Most of the patients, they lie onto their side. So is there any specific recommendation that this affected shoulder should be we should not be lying on that affected shoulder, or it should be up, or any other specific posture recommendation that the patient should follow?
The pain happens in extreme rotations and extreme abduction usually. So what if the patient is not having pain on the, if he is lying down on the pain side of the shoulder, we'll encourage him to do that. There's no point. There's no problem if it is not causing pain. In case if he is having pain on that shoulder, if he's lying down on that side, then we will ask him to lie down on the other side, but he has to keep 1 or 2 pillows before him so that the arm, the painful one arm, is actually rested on the pillow, and even in his sleep it doesn't change its position. It's rested on the pillow properly and it doesn't fall off to the extreme positions which can cause pain. That usually takes care of the position.
Okay, Hemjan, thank you for the comments. So, as per your opinion, I believe he's on the path of recovery, and even though it is 3 months, it is not a reason for concern, which is reassuring. We'll get back to you on that if we have any other questions. Thank you for your comments. I'll take comments from Dr. Vijay. Vijay, I believe physiotherapy has a significant role in these patients. I believe after the initial phase of rest, it's the physiotherapist who is getting the patient his movements back and equally relieving pain. So how do you look at this patient, and what is the role of physiotherapist, and what actually do you do, and what gadgets do you have to play around to help them get their movement back and get rid of this pain? Over to you, Vijay.
Thank you for inviting me for the discussion. I completely resonate with Dr. Hemchand, sir. This is an actual pathway that anyone would adopt actually. Initially, when there is a improvement or 80% of in 1 month itself, it's definitely a positive response from the patient. End range movements, end range pain or end range movement deficit or end range pain or pain during sleeping positions usually are the complaints which will come from patients who are 60 years, 65 years of shoulder impact injury, something like this. So what we do is from day one, on the protocol, what we usually adopt is, so there is something called closed kinetic chain exercises, which not just work on cuff muscles and the other key muscles of shoulder. It also works on the periscapular area muscles along with the upper back muscles. This will actually steer better when you actually recover to the extent of this over a month. So the end range movement, end range deficits will be betterly addressed when you start with this kind of exercises. These are basically not individual muscle practices. These are basically a pattern of exercises which will actually give rise to good amount of functional movements. The patient can be functional the same way patient can be active and pain will be very less. Same time he can involve his periscapular muscles, which will actually help him to gain good amount of range and good amount of strength around the cuff also. When this kind of a scenario exists, the patient still have pain as Dr. Hemchand has told. What we usually do is we do a short-term course of laser, which will actually facilitate better pain management, and then we also teach them certain exercises during just before going to sleep or just waking up from the bed. Those activity drills will definitely enhance his capsular stretch, which is crucial to get more amount of range and then better pain control. The very routine barrier that what we see is the adherence. Whatever exercises we say, the moment they gain the usual pattern, the moment they gain the functional range of 90 degrees to 120 degrees, they usually lessen the intensity of exercise practice. That's when the end range failures or end range joint restrictions are seen routinely. So the barrier is not just a protocol or the management from the orthopedician. The patient taking it so serious till next 6 to 8 weeks to make it so steady and fully recovered. I think this is all it is required now at this stage if this is a scenario.
What is the role of these therapies, which we hear, the TENS or interferon therapy or infrared therapy?
Yeah.
Do they have role here? When do we use them?
They are the routine recommendations usually, sir, probably at a very early stage. But once the pain is not so high, or the patient is able to bear the pain with the moment, usually their effectiveness is not really published well, or they are not the actual ones to make anything become better. Likewise, a lot of patients believe this IFTs or IRR lamps or ultrasounds will definitely help in gaining the range also. So in introducing these modalities in the first node or the first case will keep them aside, in them aside, that this is going to help me a lot. So IFTs, IRRs, yes, they help, but not to the large extent. Only exercise practice and strengthening protocols of cuff is only going to help in these cases. But to go along to deal pain in very early stages of mobilization, this can be introduced, but their effectiveness is not so high.
What is the role of chiropractor? We hear about chiropractors. Who are they and what is their role, and do they help this patient?
In this case, there is no role of chiropractor, sir. To be honest, in India, we don't have a course of chiropractic offering from any college or any university as such. This is, it is my practice of experience that I'm sharing. I was also in West. I was in Johns and all. So there they have a lot of chiropractic universities offering a lot of courses, but majorly they are more towards spinal adjustments and alignments. Of course, peripheral joints also they mobilize, but in this case, it's a soft tissue injury. There is no great role of chiropractic. It is all about strengthening the cuff muscle. Chiropractic, if you ask me anything from the chiropractic in this case, is only placebo. There is nothing else chiropractic can adjust, because there is a great improvement of joint range up to 80 degrees, and it's only the muscle strength that have to be gained, as he's a 69-year-old candidate, and already he must be having some kind of muscle weakness or atrophy because of the aging factors that have to be worked on. That's all. There is no significant role of chiropractic in this case.
When we talk about these connective tissues and the fascia or the ligaments which are probably getting involved here, we currently hear these massage therapies, or the so-called commercially available massage guns. Do you think they have any role in helping these patients to release that tension which is there in that subcutaneous tissue or the joint capsule, and help him relieve that adhesions which are there? Any role of them?
No. In peripheral joints, I would definitely not recommend guns or massages, because there is no role, and when we apply them on the shoulders, we doesn't have great control how much intensity it is delivering on the tissues. At times, it may re-injure also, because in this case particularly, there is supraspinatus involvement and the cuff involvement. There is a tear actually. So if there is a tear, then this kind of massage guns or anything like that will definitely aggravate the injury, because there will be underlying osteoporosis, there may be underlying atrophy of the muscle tendons itself. But in case of spinal muscle spasms or periscapular muscle tightness, especially population from sports practices, those population can get help a bit in a very little time span. But majorly in peripheral joints, there is no role of any physio guns or massage guns, because largely we cannot really fine tune the intensity of the vibration delivery to the shoulder joint. And there are no guidelines that have come out with the effectiveness of this massage guns or anything.
So I guess we continuing the same thought process. This whole Ayurvedic or other massage therapies are also
Yes,
necessary
yes,
for this patient.
yes. No, not required at all. It's all strengthening practices. It is taking time. It will take time. Better. There is a method called CBT that we usually employ on patients who are recovering little late. This is nothing called cognitive behavioral therapy. Patient should definitely believe this is going to take time, and this is he's going to adopt, the tissue is going to adopt long time to get into full range of motion. We have to counsel him in every session positively, and then we have to motivate him and get a good amount of adherence at the home. That's the success thing rather than approaching anything else.
Thank you, Vijay sir. Thank you for your comments. Yeah. So this patient continues to have pain, and as it is frequently bothering his sleep, and that lack of sleep is equally kind of affecting his day-to-day activities or the daily chores. So he wants to kind of get relief or comfort from this pain. We are currently seeing these pain clinics, which are a bit getting frequent nowadays. And so, Nagalakshmi ma'am, I want to hear from you. What is the role of pain clinics, and how would you see this patient, and how can you help this patient?
Yeah, good evening. This is basically an chronic pain patient with frozen shoulder on which there is an acute injury. That's the trauma which he had in the bus. So basically, as it was told, there could be a partial tear of the rotator cuff upon the frozen shoulder. And because the rotator cuff tear needs rest and the frozen shoulder needs movement, so there is a restricted range of movement under which we can do physio for the first few weeks, right? So this is the gist of the thing which for this case we need to do. But yes, we as pain physicians, we believe in early rehabilitation, and particularly when there are various safe procedures which can help in early rehabilitation, I think we can go for it. Particularly a frozen shoulder or a rotator cuff tear patients, for them the treatment management is mostly NSAIDs. And NSAIDs cannot be given chronically for 3 months or 6 months or 9 months till the patient requires for the whole rehabilitation. So yes, we need not go for an MRI in the initial setting, but most of the pain clinics have an ultrasound, and like I do a dynamic ultrasound in my pain clinic to see if there is any partial tear or there's an intrasubstance tear or there's a complete tear. Yes, when there is a complete tear, it's definitely a surgical indication. But when there's a partial tear which is not responding to the rest which we give with the medications, then yes, I have done quite a good number of cases of regenerative therapy, and we've given for partial tears and intrasubstance tears platelet-rich plasma, which has helped in early healing of the tears. So basically, if the rotator cuff tear is healed early, then the frozen shoulder rehabilitation will also be fast. And the patient need not suffer with pain, particularly it is his right hand, and he'll keep on using his hand. And whenever there's a continuous pain, sleepless nights and all, we generally do shoulder denervation, but yes, it could be just a steroid block or a radiofrequency ablation of the shoulder, which will decrease the pain intensity. Decreasing the pain intensity has two advantages. One thing, the physio becomes quite easier. And the other thing, the patient need not suffer pain just because he has diabetes and he has frozen shoulder. So most of the time we see this erosive capsulitis where all the ligaments of the shoulder have adhesions. So we generally do a hydrodilatation with or the prolotherapy, which we tell either with normal saline or dextrose giving good results. And we remove all the adhesions of the patient. That itself gives a very good movement. It is only that after this movement which the patient gets, he has to do a continuous physio. There's no doubt physiotherapy is the mainstay of treatment for frozen shoulder. But what we do is to facilitate the physiotherapy, make the patient comfortable so that so that his pain is decreased without the use of much medications, particularly NSAIDs. And so that his functional ability would be more. And basically, because particularly for this patient, it being the right hand, all this job works or what all he does, so that if anything, if there's a continuous pain, it doesn't only affect his function, it affects even his mental and psychological ability. So early rehabilitation is necessary. Physio is the mainstay of treatment. But yes, to facilitate physio, you have very safe procedures like hydrodilatation for the frozen shoulder and radio frequency ablation of the nerves which supply the shoulder joint. Hello?
Yes, ma'am. Ma'am,
Yeah.
you mentioned about plasma-rich, platelet-rich
Yeah.
plasma therapy.
Yeah.
Is it for patients who have tear, or is it also for patients who do not have an tear and they have a frozen shoulder?
No, it is for patients who have tear. There is
Okay.
no PRP evidence. Actually, even there is no FDA approved guidelines even for tears in, I mean, shoulder joint or in, to be frank, in any other joint. But yes, there are evidence based papers, and PRP is being used regularly. So, and I've used it quite regularly and I have very good results. Partial tears, yes, the patients respond very nicely for PRP. But as said and done, PRP also doesn't decrease your pain as soon as you give it, because it helps in healing. As the muscle or the tendon gets healed, then your pain decreases. So rotator cuff injuries, the rest is the primary state. PRP only helps it in healing, so that after the rest period, when you start physio, the tear shouldn't increase or it shouldn't cause pain. So once the tear is healed properly, then I think the further physio would be very easily done.
You mentioned about the role of NSAIDs. Yes, we understand that NSAIDs reduce inflammation and they're very effective analgesics. But as a cardiologist, we are very scared of prescribing NSAIDs and almost nil. So we don't have enough guts to prescribe NSAIDs to a patient, particularly who is hypertensive and elderly. All the complications they come up into our mind, and as a cardiologist, at least I don't have the guts to prescribe an NSAID for him. But
Yeah,
that
true.
should
That's
not.
why, I mean, when we have safer alternatives, like what all blocks we do it under real-time imaging with ultrasound. So the safety margin is quite high. And if I speak of PRP, it is the patient's own blood. That's the autologous blood. So there is no, I mean, uh, blood interactions or blood reactions which we need to get scared of. And even the radio frequency ablation of the nerves, which I say, it is not that you're burning the nerve totally, that the function of the motor function or the sensory function of the muscle is gone. Now you have quite different ways of radio frequency ablation where only the pain fibers of the nerve is numbed, the motor and the sensory functions are intact. The only disadvantage of this kind of radio frequency ablation, which we call the pulsed radio frequency ablation, is that it is not long lasting, as with other radio frequency ablations, where you can expect a period of 2 to 3 years of relief. Pulse radio frequency ablation maximum gives you a relief for 1 year. That is the max. So in this 1 year, I think if the rehab, if it is the physio, if it is done properly, he should recover quite early. He doesn't require even that 1 year of pulse radio frequency ablation pain relief also. And all said and done, the patient still has pain which is disturbing his sleep. So because if there is no tear, we need not order an MRI every time, being cost I mean too expensive. Some are claustrophobic and various issues. But yes, in the OPD with an ultrasound near us, we can do a dynamic examination. In fact, in an MRI, you even can't do a dynamic examination. In ultrasound, we can look for the impingement. You can look for so many things by doing a dynamic examination. So if there is a tear, yes, give rest and then follow it with the physio for the frozen shoulder. But if there is no tear, you can do an early rehab. You need not wait for the injury by giving rest for the patient so that his pain decreases, and then you start the rehab. So frozen shoulders and all, early rehabilitation definitely give good results. I think both the Dr. Hemchand and Dr. Vijay would agree with me. So what we do is only to facilitate the physio so that it's done early and the range of movement is increased at an earlier stage.
Ma'am, can you walk through us about the procedure of this PRP transfusion, ma'am? How it is done? Is it an OPD basis? How do we collect the blood? How do we do? Can you just briefly walk through us
Yeah,
to a typical
platelet rich
session?
plasma, actually you have different companies centrifuging machines and all. So it depends upon the company which you take, but generally on an average, we do a double centrifugation method, and around 20 ml of your blood with anticoagulant accounting to total 25 ml, we get around 4 to 5 ml of PRP. So depending upon the amount of PRP we need, the amount of blood we draw depends. So like in KIMS where I work, we take 10 ml of blood for 1 ml of PRP. Whereas in my own clinic, I take 20 ml of blood for 4 to 5 ml of PRP. So it depends upon the machine which you're using, definitely. So on an average, depending upon the tear, if there is a intrasubstance tear which is very big, it is not a complete tear, then maybe you'll need 2 sittings. We do the scan prior to decide how much ml of PRP we require. So once we collect the patient's blood, we do a double centrifugation method, and the above supernatant plasma is removed, and the middle portion is the PRP, which we inject directly into the tear by doing an ultrasound scan. That is how I do a regenerative therapy, let it be for shoulder, for epicondylitis, for knee, plantar fasciitis, anything. We just scan it prior to see the extent of the tear and then decide the amount of PRP we require. But the prerequisite for a PRP is that the patient should not be on any NSAIDs, antiplatelets, steroids, and if possible, statins for at least 3 to 5 days prior to the PRP and 3 to 5 days after the PRP. That is the most limiting factor for PRP. NSAIDs at least can be stopped, but antiplatelets cannot be stopped for most of the patients, particularly frozen shoulders, where we see at elderly age group with diabetes. So most of them have at least ecosprin in the background as a preventive measure. So if there is any, it is given as only as a preventive measure, then I think yes, we can safely, considering the safer margin, we can stop the antiplatelets. But if the patient has any prior cardiac issues and all, stopping the antiplatelets would be difficult.
And I believe this is a daycare procedure, madam.
This is a daycare procedure. We just observe the patient for 1 hour and we send them away.
Okay.
It is a daycare procedure. The
Yes.
patient can come, get the PRP done, and just move out in 1 hour.
And
It doesn't
usually
require any admission.
how many sessions on an average does a patient require? And how
See,
frequently do we do?
if it is a very small tear, it requires only 1 session. It requires only one. Most of the shoulder injuries require only 1 session, unless there is a very big intrasubstance tear, which would require 2 sessions at an interval of 2 to 3 weeks. We generally scan the patient again and see how much the patient has recovered, how much the muscle has regrown, the tendon has regrown, and then we decide for the second sitting. That is how I routinely do it.
You mentioned about denervation as well. The term
Yes.
denervation itself is a bit apprehensive.
Yeah, I know.
You mentioned that it is effective. We can
Yeah.
understand by denervation, the pain should go away. But
Yeah.
what are the long-term complications or problems associated with denervation?
So the most, panicking for us is if we say denervation, yes, you're denervating the joint. So the motor function of the joint is gone. The shoulder can get dislocated, sensory is gone. See, that depends upon the kind of radiofrequency ablation we do. When we are dealing with mixed nerves, we do only pulse radiofrequency ablation that doesn't cause any sensory or motor loss to the nerve. So we safely do a suprascapular pulsed RF ablation for most of the patients. Even in my clinic and even in KIMS, we've been doing it. and it gives very good results. Yes, if the patient has very severe frozen shoulder, very severe pain that even slight movement is difficult, we see quite a few patients whose range of motion is hardly 30 to 40 degrees, abduction and external rotation and all. And if the patient is not willing for an RF, or there are any apprehensions related to that, what we do is we put in a catheter at the suprascapular notch, and we give and we just tunnel the catheter and fix it. So before the physiotherapy, we just give a dose of the local anesthetic, sensory dose of local anesthetic, so that the pain decreases and the physio is good. So it being a peripheral nerve catheter, you can happily keep it for 10 days to 2 weeks. And in these 2 weeks, if the physio is done properly, most of the movement comes off and he has to follow it later. So this is one way which we can do. The other way, as I told you, you need not worry for pulse radio frequency ablation. It is done under ultrasound imaging. So the complications are extremely low. It is only that you need to know how to do the technique, how to adjust the voltage, how to adjust the temperature and the time. So it all depends upon your clinical acumen to do that. But it is extremely safe.
Thank you, ma'am. I think these are the questions that I had in my mind. I'll open the forum for any questions. Anybody has any questions to either of the experts or any thoughts, please feel free to express. In the meantime, I'll ask Dr. Shankar sir to share his thoughts on this case, and how would you manage, sir, and any thoughts that we can discuss.
Good evening to all. First of all, I congratulate Dr. Anoop and Dr. Praneeth for the completion of 125th Huddle session. This is really, we have gone through a different journey. The management of this frozen shoulder, a lot of advances have come. We have heard from Dr. Nagalakshmi, Dr. Vijay, and Dr. Hemachan. So really, it has enlightened me a lot. Only thing is, I remember the words of Judge Bernard Shaw. Once he told, to the person with a toothache, even if the world is tottering, there is nothing more important than a visit to your dentist. So, so pain relief is very important, and the greatest thing or the help or assistance one can provide to the mankind is pain relief. So definitely, I invite the pain clinics should come and relieve the pain, the suffering people. So many advances have come in this pain management. So even in the pharmacotherapy, neurotransmitters, we know regarding the neurotransmitters and the receptor pharmacological agents, they allowed the development of neurotransmitter antagonists and the modulation of ionic channels and the use of enzyme inhibitors. The advanced pain therapy. Now we are seeing in many of the pain clinics which have come in Hyderabad. So the options with the spinal cord stimulation, implantable infusion devices, regenerative medicine, the radiofrequency ablation, and spinal endoscopy, especially these endoscopic procedures in disc prolapse and other. So they change the face of pain relief measures from non-specific treatment to more predictable results. So I congratulate, I thank at the same time Dr. Nagalakshmi, Dr. Vijay, and Dr. Hemachandra, who have enlightened regarding this. When the patient comes with the complaints of shoulder pain, then how to approach. This is really a enlightening session for me. Thank you, one and all.
Thank you, sir. I have one question in chat box. So speaking with pain management, can we manage chondromalacia patella similarly, or do we need to get the patient follow up with orthopedician or a physio alone? And any preventive measures for the same, sir? I believe this question Dr. Hemchand can answer. Hem, if you are there, can you take this question?
Yes. There are 2 points I wanted to add before actually answering this question. That is one. One thing is the pain relief is not the whole intention of the treatment in few conditions in the shoulder. Like the tendinitis, if you have the supraspinatus tendinitis, it is the inflammation. So it requires some rest for it to improve. Okay. The pain is actually a what do you say, is a protective mechanism. It prevents few things to be for the patients to avoid few things. So for few conditions, just pain relief, the physio should not be started immediately. We have to wait for the tendons to what do you say, heal. That is one. Second point is if there is a tear, we have to also rule out if there is an acromion which is actually impinging and causing the tear. If it's just a injury which is causing the tear, then yes, the PRPs, all the things will come into play. But in case if there is an acromion which is impinging and which is causing that tear, that has to be addressed. Otherwise, the PRP or whatever modalities we use, once the pain comes down, the patient actually goes back to his movements. The impingement will again cause the tear. These are the 2 points which I wanted to add. And coming to this question about the chondromalacia patella, again, it is not just the pain relief which is required. Usually it is for the younger age people who have the chondromalacia patella, it is the patellar cartilage which is which gets, what do you say, softened because of the maltracking of the patella. The maltracking of the patella happens because of the weakness of the thigh muscles. So for these patients, usually there is some things which he has to stop for at least 3 weeks to 6 weeks for the cartilage to regenerate and get back its consistency. That is the thing. So what they have to be stopping doing is they should not be doing any activities like jumping, jogging, running, skipping things. They can walk. They have to avoid sitting on anything which is there below the knee level. They have to sit on anything which is above their knee level. They have to avoid, as I've said, any running activities. And that has to be followed for at least 3 to 6 weeks of time. That is first thing. Second thing is, again, they have to go to the physio, where the physiotherapist will actually make the thigh muscles stronger, mainly the vastus medialis obliquus, which is usually weak for many of these patients. And once they start strengthening, the maltracking actually gets corrected. So the change in the lifestyle will actually make the cartilage to heal. That is one. Second thing is the exercises will make sure that the tracking happens properly so that that doesn't recur later. These are the 2 points. If the chondromalacia patella is grade 4, where the cartilage has already gone, then they usually require some procedures like microfracture to regrow the fibrocartilage, not the hyaline cartilage. And second thing is, if that is a small area, then usually chondral transplantation. And if it is very too much of damage, then only patellar reconstruction is also mentioned. But usually in the younger age, unless and until it is because of trauma, grade 4 is very rare. So the lifestyle modification along with physio usually takes care of the problem in about 2 months or so.
Yeah. Thank you, Hemchand. Samraju sir, your comments on today's session, sir.
Praneeth, I joined late. Sorry. Was it a frozen shoulder?
Yes, sir.
Okay. I just wanted to ask, what are the ways of preventing it? Does yoga has any role? And diabetes mellitus control and also vitamin D deficiency, do they play any role? To repeat, role of yoga, vitamin D deficiency, and yeah, diabetes control. If it's already discussed, please ignore what I said. But otherwise, if somebody can add on it, thank you.
Yes, sir. Dr. Hemchand, can you take the diabetes and vitamin D? Maybe yoga, I will ask Vijay to answer.
Yes, sir. The age, actually, elderly age group is one of the risk factor for the frozen shoulder. That is one. Second thing is the risk factor of diabetes, mainly irregularly controlled. Uncontrolled diabetes is one of the risk factor. To prevent the risk of diabetes, yes, controlling your sugars will make you like a regular normal person without diabetes. So that definitely decreases the risk. But age is always there. And second thing is, yes, yoga or any exercises which actually help you in keeping your joint mobile. That usually takes care of the frozen shoulder, sir. Usually it starts with some pain in the shoulder.
We lost you for a second.
Usually, can you hear me?
Yes, yes.
It usually starts with some pain in the shoulder where because of pain you stop movements and it actually ends up with stiffness of the joints. So if you have any exercise, yoga or any exercise which actually make sure that you mobilize your joint regularly, frozen shoulder can be avoided.
And role of vitamin D?
So role of?
Vitamin D.
There is no role of vitamin D per se, sir.
Vijay, would you like to have add anything in particularly in relation to yoga and frozen shoulder?
Sir, in terms of prevention, definitely yoga is all about stretching the key muscles of the body. So definitely it will add value as the person ages himself. Because age-related changes like stiffness and atrophies can be definitely addressed well when a person is diabetic and have a comorbidity, and if there is any signs of shoulder stiffness and early onset of pain and stiffness, yoga will definitely add value in preventing further progression of the shoulder pathology. But if there is a tear or if there is like today's scenario, if there is a tear or if there is any sudden impingement or a situation like this, I think yoga can be continued once he gains good amount of shoulder control. Slowly, probably once he gets good amount of pain control, with the advice of orthopedician, he can definitely start yoga probably after 3 to 4 weeks of time. It will definitely add value along with physical therapy.
Yeah, thank you, Dr. Vijay. I think the yin style of yoga where you hold the stretches for long time, which particularly focuses on stretching the fascia and ligaments, probably should help prevent frozen shoulder. Any comments? Anything?
Yeah, definitely. Okay.
I think somebody wants to share. The forum is open.
Yeah.
Please. Yes, ma'am.
Thank you, Dr. Hemchand, for your inputs. But only thing which I wanted, like, whenever we do a PRP or something, we do look for subacromial impingement by doing a dynamic ultrasound. And yes, pain is definitely a protective mechanism, and we cannot ablate pain for all procedure, for all the uh, uh, all the diseases or anything symptoms of the disease. But once you have decided that the patient has a frozen shoulder and there's no other ailment or no other cause which is significantly causing his sleepless nights and all, then at that stage, I think we can venture and we can do the denervation or PRP or hydrodilatation or anything of so. So yes, we do need to rule out all other things prior to doing any procedure. Just because it is safe or just because it's a percutaneous procedure, we cannot do it on every patient. Only after ruling out so many things that we decide on a procedure and then go for it. All frozen shoulders are not glenohumeral joint arthritis. Yes, we have done joint injections prior to doing hydrodilatation for most of the patients, but after now doing both the procedures, I see hydrodilatation has given better results for frozen shoulder than just a glenohumeral joint injection. So yes, the intervention depends upon the disease entity, and clinically diagnosing with all the tests which we do clinical, when we examine the patient clinically, roughly gives us an idea of what it is there. And when we do a dynamic ultrasound, we at least get it to the near precise decision making. And yes, the higher end is MRI, which we can definitely order whenever we have a doubt. So tendinopathy, tendinitis, yes, rest is the major uh, thing which we need to do. But yes, what all I've told was for frozen shoulder and not for a tendinitis or tendinopathy.
Yes, ma'am. Point well taken. It is 9:12. Before we wind up, anyone else has anything to share? If not, I'll ask my co-host Anoop to share his closing comments.
Thanks, Praneeth. As I was listening to Dr. Hemchand, Dr. Nagalakshmi, and Dr. Vijay, and Shankar sir's comment, and of course, Somaraju sir's comment, and I myself, with the kind of whatever background, lack of expertise, I would say, I shouldn't say expertise, that I possess. These are the kind of topics where we all should have at least some basic knowledge that are scientifically based, with topped up with our practical experiences. So I'm not sure if there is a way by which we can replicate these kind of discussions, either in a written format or in a more visual format, where not just patients, but even doctors like us, they can frequently refer to, so that we keep ourselves upbeat with what all is happening, like dynamic ultrasound or nerve blocks or RFA, and their supposedly very rare side effects in terms of the neural blockade. These things, while it sounds very objective and very straightforward for Dr. Nagalakshmi, these are something which I must admit that I'm not quite familiar with, and I'm not quite sure doctors who are not dealing in the field of orthopedics or physiotherapist or pain control are quite familiar with, let alone patients. So I would certainly would love to engage in any offline discussion with my guests in terms of how we can put a little bit of like a visual representation of what all we can do, or what all are the options for not just for frozen shoulder, but also for other orthopedic morbidity, where we can reduce the pain, where we can improve the functionality or whatnot. I think that the points which are made in today's discussion, I'm sure people are going to refer back again and again for them to get understanding of what all we can do, so that you don't leave patients like what I have been doing so far, which is paracetamol, muscle relaxant, and tell them go and do exercise at home. I think there are better ways we can manage these patients, and what we are discussed today is definitely a step forward for it. Thank you.
Dr. Anoop and Praneeth, can I say something?
Yes, sir.
Yes, sir.
Continuing on what Dr. Anoop said, each one of us specialists should continue to keep in touch with internal medicine, general medicine. And I keep telling my colleagues, and when we teach students from different specialties, It is extremely important. Whatever specialty you practice, keep in touch with internal medicine. Read every new edition of Harrison. The 21st edition of Harrison is available. It is one of the best books written in the recent times. And secondly, Oxford Textbook of Medicine. There are 3-volume book. Is also available. Whichever you like, or both you like. And that makes our patients safer for each one of us specialists. Thank you.
Absolutely, sir. I think getting touch with medicine is extremely important, and definitely point accepted, sir. So it's 9:16. With today's session, we completed 125 sessions. It's a long journey. So weekly huddle is hosted every Wednesday, 8 to 9 p.m. The link is the same. We record every sessions. All the sessions so far have been recorded and uploaded on YouTube and the podcast. We will be joining you again next week with a new topic. Please do join us. And if you have any other topics that you think we should discuss, feel free to share. Thank you everyone for joining tonight, especially my guests, Hemchand, Naglakshmi, and Vijay. Thank you everyone. Good night. Please take care.